It will appear live after some time. Huh? It's being sent to the YouTube. Then you can start.
You can start, Dr. Navjot.
Good evening, everyone, and welcome to ISA National Online PG classes. These classes are held every Monday. Myself, Dr. Navjot Kaur Sandhu, Senior Resident, Department of Anesthesia and Critical Care, Gyan Sagar Medical College and Hospital, Patiala. I am one of the screen coordinators for today's session. And for today's session, the topic is case discussion on chronic liver disease for liver transplant surgery. Before starting the session, let us seek the blessings of Ma Saraswati by listening to Saraswati Vandana. Now I request Dr. Sukhminderjeet Singh Bajwa sir, Honorary Secretary, ISA National, to kindly address today's session.
Thank you, Dr. Navjot. Today's topic is actually quite interesting one from all angles, academic, clinical, and from learning point of view, because these are the special cases. The liver transplant, they are require a specialized centers for such patients to get operated, and majority of the time there's end stage liver disease where we land up for the liver transplants, and invariably these patients have the comorbidities, other comorbidities also, which makes the transplant surgeries more challenging. And definitely the institutions like AIMS, they are always leading, institutions to tackle such surgeries. Although corporate setups are also there. So Dr. Vaishali, Dr. Sunena, and their team, they will be dwelling upon the important aspects of liver transplant anesthesia and how these patients, how to optimize and how to deal with the challenges which arises intraoperatively or post-operatively also. I think interesting class also. The UPG students get a long question also sometimes, and you may get a long case also with the hepatic failure in the sometime in the emergency it comes. You can have it in examination table. You have this long case. So I think everybody should pay attention to whatever is being discussed today. Very basics we will be touching up, not the advanced things. And I request Navjot to introduce the faculty.
Thank you, sir, for your valuable insight on this topic. Now I request Dr. Ashmita Anand, my co-screen coordinator for the day, to introduce our esteemed faculty as well as outline the format and rules for this session. Over to you, Dr. Ashmita.
Unmute yourself. Ashmita, unmute yourself.
Good evening, all. This is Dr. Ashmita from Tamil Nadu, currently working as senior resident in Government Polur Hospital, Tiruvannamalai district, Tamil Nadu. I take immense pleasure in inviting the today's moderators for session. I extend my warm welcome to Dr. Vaishali Vandeskar, Madam, Professor and Head, Department of Anesthesiology at AIMS, Bhopal, with 21 years of PG teaching experience. Madam's special area of interest includes airway management, pediatric anesthesia, onco anesthesia, and palliative care. Madam has been a faculty for many international national conferences, and ma'am has been the recipient of many awards, which includes ICMR grant of worth rupees 48 lakhs and 27 lakhs, and as a co-principal investigator in ICMR Studentship Award of rupees 50,000. And Madam owns publication of about 40 in number and 6 book chapters. I extend my warm welcome to you, Madam. And I also extend my warm welcome to Dr. I'm sorry for the interruption. I shall do the screen sharing again. I also extend my warm welcome to Dr. Suena Tejpal Karna, Madam, Additional Professor, Department of Anesthesiology from All India Institute of Medical Sciences, Bhopal, with 15 years of PG teaching experience. And Madam's special area of interest includes transplant anesthesia, difficult airway, pediatric airway, and simulation. Madam's achievement includes as published H-index articles of 14 in number and I-index of 15 in number, which includes citations of 1,300. Madam has been a reviewer in many national, international PubMed indexed journals. Madam has been a faculty in international, national, and regional conferences and a recipient of DHR ICMR Young Medical Faculty PhD Research Grant in the year 2024 of rupees 50 lakhs and ICMR Research Grant as a co-principal investigator and ICMR grant of 50,000 for PG students. And Madam owns publications of more than 50 in PubMed indexed publications and 3 book chapters. I welcome you, ma'am, for today's session. Before we begin, I have general rules for the audience. Kindly stay muted and turn your videos off. In case you have any queries, it can be typed in the chat box. The questions will be addressed at the end of the session. Thank you for your kind cooperation. I now hand over the session to today's moderators to introduce their PGs and continue the session. Thank you, ma'am.
Thank you, Dr. Ashmita, for the nice introduction. So today we are presenting a class on chronic liver disease for liver transplant. And liver transplant is the treatment of choice for end-stage renal disease actually. And when the liver diseases are progressed to a stage where the recovery is not possible. So today I am having 2 PGs with me, Dr. Ujjwal Gupta and Dr. Preeti Prajapati, who will be presenting this case on chronic liver disease. So over to you, Ujjwal.
Good evening, everyone. I am presenting a case of 42-year-old male patient, resident of Bhopal, shopkeeper by occupation, who was admitted in AIMS on 16th October 2024 with a complaints of yellowish discoloration of eyes and urine since 3 months, abdominal distension since 1 month, shortness of breath since 15 days, and altered sensorium since 4 days. History of presenting illness was narrated by his wife. He was apparently normal 3 months back when he developed yellowish discoloration of eyes and urine, which has now progressed to all over his face. It is not associated with any itching, clay-colored stools, bulky stools, fever, chills, rigors, or pain abdomen. He also has history of abdominal distension since 1 month, which is gradually progressive. It is associated with mild abdominal discomfort, but is not associated with any nausea and vomiting. He also has a history of shortness of breath, which was initially on climbing 1 flight of stairs, but now it has increased to doing routine activities since 15 days. He also has increased dyspnea in sitting position, which subsides on lying down, but is not associated with any chest pain, palpitation, syncope, fever, or waking up from the sleep due to breathing difficulty.
Okay, Ujjwal. What are the differential diagnosis of yellowish discoloration of eyes and urine that you have mentioned in your complaints?
Ma'am, yellowish discoloration of the eyes can be either due to physiological cause, that can be due to carotenemia, or pathological causes. Pathological causes can cause either unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia is mainly due to the hemolytic causes. As I have mentioned in the screen, autoimmune hemolytic anemia, hemoglobin disorders, hereditary disorders of conjugation, red blood cell enzyme disorders, and red cell membrane disorders. Whereas conjugated hyperbilirubinemia can be due to intrahepatic cause and the post-hepatic cause. Intrahepatic cause that affect mainly the liver parenchyma and cause the hepatocellular damage, as the most common causes are viral hepatitis, alcoholic liver disease, non-alcoholic steatohepatitis. And post-hepatic causes can be due to any obstruction. It can be intraluminal or extraluminal obstruction.
Okay. So you tell me what is the significance of the negative history that you have asked?
Ma'am, negative history of itching and clay-colored stools rules out the causes of obstructive jaundice, whereas the negative history of fever, chills, and rigors rules out the infective cause of jaundice, for example, cholangitis, and pain abdomen rules out the gallstones associated with jaundice. Negative history in abdominal distension, that is nausea and vomiting, it rules out any obstruction, any bowel obstruction related to it. With shortness of breath, because our patient does not have chest pain, palpitation, or any history of syncope, so we can rule out the cardiovascular causes of shortness of breath. Cough and fever rules out pulmonary causes, and waking up from sleep due to breathing difficulty can rule out the paroxysmal nocturnal dyspnea.
Okay, you have mentioned something. The dyspnea is increased in the sitting position and relieved on the lying down. What is the significance of this history?
Yes, and this condition is known as the platypnea. Platypnea is defined as a difficulty in breathing in sitting and standing position and relieved on lying down position. There are various causes for this condition. It is mainly due to the right to left shunt, that may be due to the intracardiac shunt or extracardiac shunt. In intracardiac shunt, may be due to the atrial septal defect or patent foramen ovale. Whereas in the extracardiac shunt, it is maybe due to the hepatopulmonary syndrome and parenchymal lung disease or pulmonary arteriovenous malformation,
Yes.
AV malformation.
Okay, so in your case, it is mainly because of the
Hepatopulmonary syndrome, maybe.
hepatopulmonary syndrome, and after investigation, we will find out what is the exact cause for this.
Yes.
Okay, so continue with your history.
Ma'am, patient also presented with a history of sudden onset altered sensorium with irrelevant talks 4 days back. That's why actually that was the main complaint by which patient was brought to the hospital. It was not associated with any fall, headache, fever, facial puffiness, or decreased urine output. Patient's wife also gives a negative history of any hematemesis, black tarry stools, bruising, abdominal surgery, trauma, or prolonged consumption of allopathic medicines, blood transfusions, tattooing, drug abuse, multiple sexual partners, weight loss, arthralgia, and myalgia.
So, Preeti, you tell me, what are the differential diagnoses if a patient has altered sensorium? And what is the significance of the negative history that you have taken in this case?
Yes, there are various causes, maybe the traumatic cause, metabolic cause, or toxic cause. Here we take the history of fall to rule out the traumatic cause, and headache and fever to rule out any infectious cause for the altered sensorium, and facial puffiness and decreased urine output to rule out the metabolic pathology, maybe due to the uromic encephalopathy.
Okay. Where, and you have taken other negative history also. Elaborate on that.
Ma'am, negative history of hematemesis, black tarry stools, and bruising rules out the upper GI bleed and the coagulopathy that can be due to portal hypertension. Any abdominal surgery or trauma that could be due to strictures, prolonged consumption of allopathic medicines to rule out the hepatotoxicity, blood transfusion, tattooing, drug abuse, multiple sexual partners. These history we are taking to rule out various viral causes of hepatitis, and the history of negative history of weight loss, arthralgia, and myalgia to rule out the carcinomatous cause and the autoimmune causes.
Okay. Move on with your history, please.
As I already told, that patient was admitted on 16th of October. So since 5 days, patient has undergone fluid removal of around 2500 ml from his abdomen, and he was given some medications and some fluid as informed by his wife. At present, patient is recognizing his relatives and his condition has improved.
So in this case, the patient has liver involvement, had altered sensorium, jaundice, abdominal distension. So what
Yes,
is all in the history till now pointing towards as the cause of altered sensorium? What is this pointing towards?
Ma'am,
So what is the cause of altered sensorium in your patient?
Causes of altered sensorium.
Yes.
Yes, and there are various causes of the altered sensorium.
Various causes. The cause of altered sensorium. In this case, what is that term which is used? It can be hepatic encephalopathy.
Yes, ma'am.
Right? So, and you said that initially the patient was having irrelevant talks, but now he's recognizing his relatives. Do you think whatever medications are being given?
Initially, patient when was admitted, patient was in grade 3 hepatic encephalopathy, but now in the patient grade 1 hepatic encephalopathy.
So what are the gradings of hepatic encephalopathy?
Grading of encephalopathy can be defined by the West Haven criteria. In grade 1, patient have restlessness and altered sleep wake cycle and decreased attention span. Whereas in the grade 2, patient have lethargic and flapping tremor region, and in whereas grade 3, somnolence to the semi-stupor stage, and patient have gross disorientation. In grade 4, there is a coma.
Okay. So continue, please.
Past history, patient was admitted in a local hospital with abdominal distension since 2 years back. Now he was advised salt restriction, alcohol abstinence, and some medicines, which were associated with the increased urine output, and he stopped taking these medicines by himself since 5 months. Patient was non-hypertensive since 5 years and was on tablet amlodipine 5 mg once daily. But from past 2 months, blood pressure is controlled without medications. There is no history of diabetes, coronary artery disease, thyroid disorder, tuberculosis, asthma, and fractures, and no abdominal surgeries. There is also no history of any drug allergy in this patient.
Okay. So why do you think the blood pressure, he has stopped taking the blood, this antihypertensive? There is no need of antihypertensive in this patient now?
According to history, patient has a chronic liver disease. In chronic liver disease, there is an increase in the endogenous vasodilator, which causes the splanchning and peripheral vasodilatation. Due to peripheral and splanchning vasodilation, there is a reduced systemic vascular resistance and a decreased preload. Due to that, there is a hyperdynamic circulation, and maybe that is the cause that patient need not to take antihypertensive medication since last 2 months.
Okay. And he has also mentioned the salt restriction and alcohol abstinence and some medicines. That is what you have suggested. What could be these medications and why there is salt restriction?
According to history, ma'am, that the patient give history that after some medication which were associated with increased urine output, that they may be the diuretics. So,
okay. And what is the reason for salt restriction in this particular case?
in the chronic liver disease, there is the activation of the RAS system. So maybe that's why they advise the salt restriction to inhibit the RAS activation.
Renin, angiotensin, aldosterone system.
Aldosterone system.
Okay, what can you elaborate something on that?
Ma'am, renin, angiotensinogen, aldosterone system. In this, the renin enzyme converts angiotensinogen into angiotensin 1. Post that, the angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin 2 acts as a potent vasoconstrictor. Along with that, it activates aldosterone, which causes the sodium and water retention. That's why in this case, salt restriction is prescribed, because if patient will consume much salt, it will activate the RAS system and he will retain more and more salt and water. Actually, this patient is already having abdominal distension. That's why they have prescribed salt restriction, according to me, ma'am.
Yeah, and patient is having already the cause for abdominal distension is in your case is particularly because of the abdominal distension in your case is because of what? Patient is alcoholic.
Alcoholic,
Okay.
yes, ma'am.
Yeah. And
Yes, ma'am.
what is the cause? Then what is the cause for this particular abdominal distension?
There are various causes can be summarized by the mnemonic 5F. F for fluid, fat, fetus, feces, and flatus. Here may be the cause of the fluid fragility, that is ascites, maybe due to chronic liver disease.
Liver disease and maybe portal hypertension
Portal
also in
hypertension.
particular case. Okay.
Yes.
Okay. Continue with your history. So we are having first question for the audience actually. All of the following may cause chronic liver disease except. So you have to answer this question.
For adult, it birth and plastic surgery, birth ICU.
So it's a very easy question actually. I think everybody should answer. The PG should answer easily. And the answer is
Option
that
for
is smoking.
Smoking.
Okay. We'll continue with the next
Yes.
slide.
Yes, madam, please continue.
Ujjwal, continue.
It will
Next slide.
Ma'am, there is some problem.
Okay.
Personal and family history. Patient has a sedentary lifestyle and consume mixed diet. Patient was passing hard stool since 8 days before admission, but now 3 to 4 soft bowel motion present. Urine is high colored and sleep is disturbed. Patient was reformed chronic alcoholic. There is a history of consumption of country liquor, 160 to 200 ml per day. He has stopped drinking since last 1 year, and patient is non-smoker, and there is no history of any similar illness in any other family members.
So in your personal history,
Yes.
you have mentioned that the patient was apparently constipated since 8 days and he has had altered sensorium since 5 days. So what do you think was the precipitating factor for hepatic encephalopathy in this particular case?
In this particular case, ma'am, maybe the constipation is the cause for.
Why would it cause altered sensorium and hepatic encephalopathy?
In constipation, ma'am, due to the ammonia, hyperammonemia, there is or due to portosystemic shunt, ammonia went to the brain and converted into glutamine, and ammonia and glutamine both are neurotoxic. That's why maybe it exaggerates the hepatic encephalopathy.
And what other things can precipitate? Constipation is one of them.
Yes,
What
other one is the dehydration, upper and lower GI bleed, infections, and
why does upper and lower GI bleed, any of it cause hepatic encephalopathy? Because blood is a very good culture media, right? So bacteria grow very easily in blood. And anything which is going to cause ileus of the bowel or increase production of ammonia, any of that, be it hypokalemia, hyponatremia, dehydration, constipation, GI bleed, infections. So all of these can precipitate hepatic encephalopathy. And so the treatment of hepatic encephalopathy often starts with identification of the causative factor. You start treating the precipitating factor along with the symptomatic management, right? Okay, and now you have said that patient is a reformed chronic alcoholic. Yes. And he's consuming quite a lot of alcohol. Do you know the dose of alcohol usage which can cause liver disease?
Yes, ma'am. For males, it is 60 to 80 grams per day for 20 years, and for female, 20 to 40 grams per day for 20 years.
Prolonged consumption is there.
Prolonged consumption, yes.
Okay.
Okay. And please. Okay. Please continue.
Medication. When patient was admitted and patient was on the following medications: injection albumin 20% 100 ml at the rate 20 ml per hour for 5 days, and injection vitamin K 10 milligram in 10 ml of the normal saline slow IV, tablets spironolactone 100 milligram with furosemide 40 milligram once a day, tablet rifaximin 550 milligram twice a day, and syrup lactulose 30 ml thrice a day, and tablet thiamine 100 milligram thrice a day. To inbuilt the nutrition, racemic protein 0.8 to 1 gram per kg per day of the vegetarian source.
But patient would never give you such a specific history that I am taking kitna dose, itna ml per hour. How have you noted this history?
Yes, and this statement is noted from the treatment chart.
As the patient was admitted since 5 days, no ma'am, so we noted from the treatment chart.
So now justify.
Yes. So you tell me the significance of why they have started all these things in this patient.
Actually, post-admission, as I already mentioned in the history, that patient has undergone paracentesis. 2500 ml of the fluid was removed, ma'am. Ma'am, to prevent the post-paracentesis circulatory dysfunction, we have started injection albumin 20%, 100 ml at 20 ml per hour. Ma'am, it is advised that if more than 5 liter fluid is removed, around 6 to 8 gram of albumin per liter of ascitic fluid removal should be administered. That's why, ma'am, we have administered albumin. Ma'am, injection vitamin K was administered because it is a fat soluble vitamin.
Well, In this case, the fluid removed was 2.5 liters. Still, we have given albumin. So there must be some other things also which albumin helps with.
Yes, ma'am. It is also given in cases of hepatorenal syndrome, and it is also diagnostically given to rule out hepatorenal syndrome also, ma'am.
You want to rule out pre-renal AKI, you want to
Yes,
rule
yes,
out
yes,
that
ma'am.
it is not volume depleted. So that is usually given with albumin on the first and third day to diagnose, to treat, and also in hepatic encephalopathy. And these patients, if they are having inflammation or chronic hypoalbuminemia, sometimes with ascites and HRS ascitic tapping, this is given, albumin is given. Okay.
Yes, ma'am.
Now vitamin K.
Ma'am, vitamin K is a fat soluble vitamin. Vitamin K is given in order to facilitate the factors such as 2, 7, 9, and 10. So actually, this is a liver disease patient, so they are already deficient in these factors. So it is vitamin K is given for that. Tablet spironolactone is an aldosterone antagonist. As I already told that there is due to the splanchnic vasodilation, there is activation of renin-angiotensin-aldosterone system. So in order to inhibit the more and more sodium and water retention, we give spironolactone. But because spironolactone is a potassium sparing diuretic, we give furosemide along with it, so that furosemide balances the excess potassium retained by spironolactone, so that patient does not undergo hyperkalemia. Tablet rifaximin.
What about the dose? Do you think it is a low dose or a high dose? 100 milligrams.
It is low dose because high dose can be increased as high as 4 times of this normal dose. That can be 400 milligram of spironolactone and 160 mg of furosemide.
And when would you say that the patient is not responding to that, or it is a diuretic resistant?
When the maximum dose is going for more than 3 days and there is not decrease in around 800 grams of weight in a week.
So even after this intensive diuretic therapy for a week, if the weight loss is less than 800 grams in 4 days, that is when you. But in Indian population, what happens is that mostly this high dose is not tolerated by the patient itself. Sometimes hypotension happens, so you have to curtail the diuretics. Okay, so it has to be titrated on an individualized basis. Okay. Go on with the next drug, please.
Ma'am, tablet rifaximin was given because firstly it is an antibiotic which is not absorbed in the gut, so it inhibits the colonic bacteria that produces urease enzyme, which converts ammonia into the urea, which could cause uremic encephalopathy.
It acts on the gut bacteria and prevents formation of ammonia, right?
Yes, ma'am.
So that is why it is given, and because it is highly concentrated in the gut, because it is not absorbed.
Yes,
okay? So rifaximin either 550 milligrams BD or even 400 TDS. That dose cannot be. And what about the syrup lactulose?
Ma'am, it has multiple mechanisms. Syrup lactulose is given to counteract the problem of constipation. First of all, also it creates the acidic environment in the gut, so that ammonia is converted into the ammonium ion, so that it does not get absorbed into the plasma and does not reach the brain in order to enhance the hepatic encephalopathy.
What is the target of giving this lactulose? What we are expecting?
Ma'am, our target is 3 to 4 loose stools per day. That is the endpoint for our lactose, that when we achieve this target, we can lower down the lactulose.
Okay. So the patient is having this type of, he has, his constipation is relieved, I think. He is passing.
Yes, ma'am. His constipation is relieved.
Are you aware of any other drugs that are given in hepatic encephalopathy besides these?
Ma'am, neomycin was neomycin was earlier given, but now it is not in practice. Also, ma'am, terlipressin is prescribed somewhere. If it is
polyethylene glycol is given sometimes. Rifaximin, you have said. Zinc is sometimes given because zinc is a cofactor for urea cycle enzyme. So that is also given. Branch chain amino acids can be given, leucine, isoleucine, valine. Besides that, even nowadays, fecal microbiota transplantation is also being done. That is also being studied. So that has also been shown to improve. See, hepatic encephalopathy is a multifactorial cause. One thing is ammonia. There are a lot of other mechanisms. There may be increased manganese, captains. There may be increase in benzodiazepines. So a lot of pathways are happening. So we are keeping it simple because it is a PG discussion, right? Okay. Now go on to the next drug, thiamine.
Ma'am, tablet thiamine is given because, as we mentioned in the history, that patient is a known alcoholic. So, thiamine is given in the patients with alcohol habituation. So, it helps the patient to recover from that. And next,
Tell me one thing. In cirrhotics, we usually say, or in liver disease, we say give high protein, 1.5 to 2 grams per kg per day. But here, only 0.8 to 1 gram is being given. Why?
ma'am, because this patient is still recovering from hepatic encephalopathy, and high dose of protein initially only can be another precipitating factor for hepatic encephalopathy. That's why, ma'am, we start from less dose, 0.8 to 1 gram per kg per day. Then we can, when patient starts tolerating, we can increase it gradually to 1.5 to 2 gram per kg per day.
Oh. Move on, please. Next slide.
In on general physical examination, patient appears to be conscious, oriented to time, place, and person. His height was about 165 centimeter, weighing 55 kg, which accounts to 20.20 kg per meter square body mass index. He is currently afebrile, 96 beats per minute, regular rhythm, normal volume. Blood pressure is 102 by 50 millimeters of mercury, measured in right arm in supine position. Respiratory rate is 16 breaths per minute, thoraco-abdominal type. Saturation measured in supine position is 96%. When patient was asked to sit down, the saturation decreased to 92%. On head-to-toe examination, I found that JVP was not raised, but pallor could not be appreciated. Icterus and yellowish discoloration was seen. Parotid swelling, diminished axillary hair, gynecomastia, palmar erythema, hystrixis, pedal edema was seen, but no supraclavicular or generalized lymphadenopathy, cyanosis, spider nevi, scratch marks, or Dupuytren's contraction could be appreciated.
Okay. So you tell me at what level, bilirubin level, the icterus will appear.
Ma'am, icterus will appear when the bilirubin level reaches more than 2 milligram per deciliters.
Okay, and in your patient, it is appeared in the eyes.
Yes,
What is
ma'am,
the
it was in
combination?
eyes, and ma'am, we can appreciate on face also.
So bilirubin is having more affinity for the elastic.
Elastic fibers in the sclera, ma'am. Bilirubin has more affinity for elastic fibers in sclera.
Okay, so that is what it is appeared in the. And what is the positive history in your this general examination? What are the positive history?
Ma'am, we can appreciate parotid swelling, diminished axillary hair, icterus, gynecomastia, palmar erythema, and hystrixis. Ma'am, these
Why?
all these all
Yes.
the signs are pointing towards the chronic liver disease, ma'am. These signs are generally present in chronic liver disease patients.
So what is the reason? And one more thing you have mentioned that the SpO2 of the patient is 96 in the supine position, and then again it has fallen to 92%.
Yes, ma'am.
So what is the significance of this particular history?
Yes, and this history signified that there may be the hepatopulmonary syndrome. Hepatopulmonary syndrome, there is a triad. There is the liver disease with the increased alveolar arterial oxygen gradient and with intrapulmonary vasodilatation. It is maybe due to there is the endogenous vasodilator increase like nitric oxide, which result in the intrapulmonary vasodilatation. And along with there is also due to the dilatation, decreased transit time and increase the distance between that. So that result in the right to left shunt. So that's why
So this condition is also known as
orthodoxy.
orthodoxy. Okay. So what is the treatment for this?
Oxygen therapy is the course to rule out the different type of shunt that, as mentioned in the earlier platypnea, there may be due to the intracardiac shunt or extracardiac shunt. In extracardiac shunt, we give to rule out the false shunt or true shunt, we give the oxygen therapy. If a patient condition is improved with oxygen therapy, then that is a false shunt. If it is not improved, then there may be the true shunt is present.
True shunt is present.
Yes.
Okay.
Type 1 and 2. Type 1, it will improve. Type 2 are true shunts. In them, it will not improve.
Yes, ma'am.
Type that you had mentioned that the cause of hepatopulmonary syndrome, right? First and foremost is the hyperdynamic circulation. That causes the decrease in transit time, right?
Yes.
And then why increased distance? Because the pulmonary capillaries are dilated. So the oxygen has to travel a greater distance in that short time. That is why there is diffusion defect, because of which there is diffusion disequilibrium and hypoxia. Okay.
Yes.
And you also asked for the lymphadenopathy. Any significance?
Ma'am,
Or
it
what
is
you
to
want to
rule
rule
out
out?
Malignant causes of chronic liver disease, ma'am. Generally, ma'am, in carcinomas, supraclavicular and generalized lymphadenopathy is seen, ma'am.
Okay. So, okay. So, what are the positive? Just elaborate the positive findings in your general examination.
Ma'am, I could appreciate icterus, parotid swelling, diminished axillary hair, gynecomastia, palmar erythema, asterixis, and pedal edema, ma'am. These are the, ma'am, positive findings. And also orthodeoxia I have observed, ma'am.
Okay, you have mentioned also the yellowish discoloration of skin also. So, is there any correlation between the bilirubin levels and the appearance of the yellowish discoloration on the body?
Yes, ma'am. As bilirubin level increases, it appears on different parts of our body. Like when the bilirubin levels reaches 5 milligram per deciliter, it appears on face, and it reaches palm and soles when the total bilirubin level reaches up to 14 to 18 milligram per deciliter, ma'am.
Okay.
Besides this, you are
So-
showing a greater pulse rate and a lower pressure, diastolic pressure. So that just shows that hyperdynamic circulation is already happening in this case, right?
Yes, ma'am.
So the patient seems to be decompensating. Okay, move on, please. Next slide.
Airway examination was unremarkable.
Next slide.
Patient systemic examination. On abdominal examination, on inspection, patient abdomen was distended with caput medici with umbilicus everted with soft reducible swelling suggestive of the umbilical hernia. All quadrant of the abdomen moves equally with respiration, and there is a puncture mark seen over the right side of the abdomen, and there is no stretch marks or inguinoscrotal swelling. On palpation, there is soft abdomen was soft and hepatomegaly with a nodular surface, and there is a no splenomegaly. And no abdominal tenderness, guarding and rigidity present. On percussion, liver dullness noted in the fourth intercostal space with liver span 16 centimeter in the mid-clavicular line, and shifting dullness was also present. On auscultation, bowel sound heard, and there is no venous sound.
Okay. So, what is the in inspection? What are the positive findings?
Abdomen is distended, so maybe ascites and caput medici are the positive finding on
Okay.
inspection.
So, what is the cause for caput medici in your patient?
Caput medici is the clinical sign of the hypertension, where it's a due to the portal hypertension, there is a shifting of the blood from the portal circulation to the systemic circulation around the umbilicus. Veins are dilated, so it appears like the caput medici.
So, it is this is the shunt between the epigastric and the umbilical vein.
Yes.
What are the other sites of portosystemic anastomosis?
Esophageal, paraesophageal, bare area of the liver, coronary, retrogastric, mesenteric, around the umbilicus, colorectal, or also known as hemorrhoidal. These are the various site positions.
Okay, these are the various sites of anastomosis.
Splenorenal shunts, paraumbilical, you have told, esophageal, right?
Yes.
Okay. And you have mentioned the hepatomegaly with nodular surface. So, what is the significance of this?
Yes, ma'am. In alcohol-induced chronic liver disease, there is a fatty deposition in the liver, which due to which there may be the hepatomegaly is present, and with nodular surface is suggestive of that there is some cirrhosis is going on. Although cirrhosis is a biopsy-proven diagnosis, but here is the nodular surface we feel, so it's suggestive of cirrhosis.
Okay, and in percussion, you have mentioned there is a shifting dullness is present.
Yes, ma'am.
How you are elicited this?
Ma'am, shifting dullness is a sign of ascites that can be assessed by percussing the abdomen. Ma'am, we ask the patient to lie on his back and we start percussing from center towards the flank. Once our tympanic note changes to dull note, we mark that area on the skin and ask the patient to roll to his other side. And when the patient roll, we have to wait for 10 seconds. And after that, we have to percuss from that point only. If our note changes again from dull to tympanic, that means the fluid has shifted. Which will suggest the fluid, which will suggest the shifting dullness. That means the fluid is moving. So this
Free
is this
fluid is
sign
present.
yes, ma'am. This
Free
sign
fluid
is,
is present in the abdomen, and how much quantity of fluid is required?
ma'am, 500 ml of the fluid minimum is required to elicit shifting dullness, ma'am.
Okay, so what are the other tests? You know any other tests which
Yes,
are
ma'am.
there?
Ma'am, puddle sign can be done. Ma'am, it is elicited when 100 to 200 ml of the fluid is there. And ma'am, fluid fill can also be done when more fluid, like 1000 to 1500 ml of the fluid is there.
Which test will you
USG.
Yes, ma'am. USG,
USG also, and minimum
USG.
100 ml of fluid you can detect with the USG.
USG
So
also.
these are some of the tests which you can detect the E.
Yes,
Okay, so in auscultation there are no positive findings. Okay.
Yes,
Go to the next slide.
On other systemic examination, on respiratory system examination, trachea is the midline with right-sided air entry decrease in the basal area and with normal vesicular breath sound bilaterally. On cardiovascular systemic examination, S1 S2 heard with no murmur and apex beat felt half-inch medial to the mid-clavicular line in the fifth intercostal space. On central nervous system examination, GCS is 15 out of 15 and S is present with all cranial nerve examination normal, and there is a delayed response to connect the dot A and B psychometric test.
Okay, so what are the positive findings, Preeti?
Yes, there is a right-sided air entry decrease in the basal area, so it suggestive of the hepatothorax. And in central
What is the
nervous
reason for
system,
hepatothorax?
Ma'am, it may be due to the movement of the ascitic fluid through the diaphragmatic opening, through the defects in the diaphragm into the pleural space. Ma'am, this is hepatic hydrothorax. It is seen in the patients with chronic liver disease. It is commonly seen on right side, but can also be seen on left side. But more common is right side, ma'am. Hepatic
Okay.
hydrothorax. Ma'am.
And if it is both sided present, what is the most likely diagnosis in the Indian scenario?
Ma'am, we should rule out tuberculosis because in Indian scenario, India is a
This is the
tuberculosis
most
capital.
common cause
Yes,
for
ma'am.
any fusion or. Okay, what other findings? Any positive findings?
yes, ma'am. On central nervous system examination, there is a astraxis present and there is a delayed response for connect dot A and B. That's suggestive of the decreased attention span of the patient. That usually seen in the grade 1 hepatic encephalopathy. When patient was admitted, patient was in the grade 3 hepatic encephalopathy. Now patient is in the recovering phase and now in grade 1 hepatic encephalopathy, and that's it.
So, well, in this, you had said that they had tapped some fluid, they had taken some ascitic fluid out. What do you think they would have done with that? The medicine guys would have.
Ma'am, with the ascitic fluid, they must have done the serum ascitic albumin gradient, ma'am. Ma'am, actually, that gradient is usually done to differentiate between the
Portal hypertension and other.
to differentiate between the portal hypertension and other causes of ascites, ma'am. So, ma'am, when the serum ascitic albumin gradient is less than 1.1, when the serum ascitic albumin gradient is more than 1.1, it suggests portal hypertension. But ma'am, when it's less than 1.1, we can rule out portal hypertension, and it can be due to other causes such as tuberculosis, ma'am.
Even when the serum ascites albumin gradient goes more than 2.5, that can also be tubercular.
Okay.
Then of course you will have to do a gene expert, ADA levels, right?
Yes, ma'am.
So okay, and you have said that there is a delayed response for connect the dot A and B psychometric test. What are you signifying with this? Why did you elicit this test?
Yes, ma'am. We elicit this test to check for the attention span of the patient. In grade 1 hepatic encephalopathy, there is a decreased attention span of the patient.
And coordination as well, they are slow.
Yes.
So any response is slow. So they will take more time to connect the dot. Another is connect the numbers.
Yes.
Right? Okay, and how do you elicit asterisks? How do you see for them?
We ask the patient to outstretch the arm and dorsiflex their hand. Then check for the to and fro motion of the hand.
Okay. Please move on to the next slide.
Provisional diagnosis of my patient. Our patient is 42-year-old male with known hypertension and alcoholic since 20 years with repeated episodes of hospitalization for abdominal distension, presenting complaints of jaundice, ascites, altered sensorium. Most likely is the chronic liver disease with decompensated with portal hypertension, ascites, hepatic encephalopathy, and hepatopulmonary syndrome.
So of course you'll be doing the hepatologist or medicine guy will be. So on that, they will be confirming whether cirrhosis is present or not. But you have very nicely said that it is decompensated. So can you tell me about the stages of cirrhosis?
Yes, ma'am. There are the various stages of the cirrhosis. First one is the compensated cirrhosis, then decompensated cirrhosis that's further classified into the stable and unstable, and acute and chronic liver failure that further divided into the grade 1, grade 2, grade 3. In compensated cirrhosis, there is an asymptomatic stage with no signs of the clinical complication. Wherein the decompensated cirrhosis, stable and unstable. In stable, there is a non-progressive decompensation with ascites and hepatic encephalopathy. Whereas in the unstable, there is a progressive decompensation with ascites, GI bleeding, and hepatic encephalopathy. And one is the pre-acute and chronic liver failure stage. There is an increased systemic inflammations, and it's developed within the 3 months. In acute and chronic liver failure, they divide into the grade 1, 2, and 3, depending on how many organs are affected. In grade 1, only 1 organ is affected, whereas in the grade 2, 2 organs are affected. In grade 3, 3 or more than 3 organs are affected. And 1 year mortality rate increase with the stage.
See that? Can you please go back to 3 slides? We missed one question there. Please, yeah.
Yes.
After the protein. So here, what is the gold standard for assessing the severity of portal hypertension? You have to choose the correct option: hepatic venous pressure gradient measurement, alanine aminotransferase test, endoscopy, or ultrasound. This is for the audience. Kindly choose.
We'll wait for some time,
10 seconds.
10 seconds.
So the audience is answering. Most of them are answering correctly. Ujjwal, what do you think is the right answer?
Ma'am, hepatic venous pressure gradient measurement is the right answer, ma'am. It is
You
the
tell me
gold
what
standard.
normal hepatic venous pressure gradient is.
Ma'am, it is 2 to 4 millimeters of mercury.
And do you call portal hypertension to be present?
For portal hypertension, it should be more than 10. And ma'am, if it is more than 12, then it could lead to variceal bleed also.
More than 5 is portal hypertension. More than 10 is clinically significant portal hypertension. And more than 12, increased chances of variceal bleeding. More than 20, poor prognosis and chances of re-bleeding. Okay, so it is very important. It is always measured in cirrhotic patients, right?
Yes,
Hepatic venous bleeding. We are measuring the free versus the wedged hepatic venous pressures. Okay.
Yes, ma'am.
Move on, please. So, can you tell me why is portal hypertension present in chronic liver disease?
I mean, chronic liver disease patient, there is actually increased intrahepatic vascular resistance due to the massive change in the structure due to fibrosis and intrahepatic vasoconstriction. And these all things occur due to the endothelial cell dysfunction, activation of the stellate cell and their conversion into the myofibroblast, which make them contractile, and angiogenesis. Actually, angiogenesis also lead to the irregular flow patterns, and due to which the intravascular resistance increase. Moreover, ma'am, due to the increase in the resistance, there is a splanchnic vasodilation, which in turn again enters the this vicious circle, ma'am. So whatever is causing portal hypertension, it again occurs because of the splanchnic vasodilation and its vicious circle, ma'am.
Yes, so there is resistance to portal blood flow, causes back pressures, causes splanchnic, increase in pressure, increase in hydrostatic pressure, plus there is hypoalbuminemia. So there is oozing from the mesenteric vessels, the fluid comes out, there is more translocation of gut bacteria, causes endotoxemia. All of this causes what? Further splanchnic vasodilation. This decreases the effective circulating volume. Effective volume is less, is sensed by the kidney, activates the renin, angiotensin, aldosterone system and the sympathetic nervous system, which leads to everything else that leads to that vicious cycle. There is hypervolemias, water retention, sodium retention, and there is only so much capacity in the peritoneum or the lymphatics of the abdomen to absorb this fluid which is getting secreted. That is why ascites happens, right? And
Yes.
because of the pressure, varices happen. Okay, okay, please move on.
So you tell me, Ujjwal?
Yes, ma'am.
Okay, we'll take the question, or we will. Okay, you tell me what are the complications of cirrhosis and portal hypertension?
Ma'am, complications of portal hypertension and cirrhosis. Firstly, as already ma'am has told, that it is a hyperdynamic circulation. Due to this
Okay.
hyperdynamic circulation, it can affect various systems. First of all, I will tell about the respiratory system. It could cause hepatic hydrothorax, hepatopulmonary syndrome, portopulmonary hypertension. It could involve cardiovascular system also, where it could cause cirrhotic cardiomyopathy, increased chances of coronary artery disease, corrected QT prolongation. It could also cause hepatorenal syndrome. If it involves CNS, it could cause hepatic encephalopathy. One of the most common complication is ascites and variceal bleed. And the infective complication of portal hypertension is spontaneous bacterial peritonitis, which occurs due to the infection of the ascitic fluid.
So it is involving almost all the systems, as you have mentioned. It is involving the cardiovascular, respiratory, renal, and almost all the system. Abdominally, we are getting the distension, fetal edema, and all the things. Okay. So these are the complications. What is portopulmonary hypertension?
Ma'am, portopulmonary hypertension occurs when the pulmonary artery pressures goes more than 20 mm of Hg, ma'am. And ma'am, if it's more than 50 millimeters of mercury, then it is a contraindication for liver transplant, ma'am. We have to wait until we optimize that, ma'am. We cannot
Yeah,
go.
we have to give some vasodilators and some therapy to reduce the pressures. Okay, so that is one of the contraindication also if it is more than 50.
So
Okay, next.
Syndrome and portopulmonary hypertension are two wide ends of a spectrum of respiratory diseases. In hepatopulmonary syndrome, there is pulmonary vasodilation because of increased endothelin 1 nitric oxide stimulation, right? And in portopulmonary hypertension, there is vasoconstriction. So you have to individualize each case. Can you please go back 1 or 2 slides? We missed a question. Yes.
So one of the systems of portal hypertension is hepatic encephalopathy, which may be the exacerbated by which of these following. First is carbohydrate waste products, second is fat waste products, third is vitamin C, and fourth is the protein waste products. So we'll wait for 10 seconds.
Mostly audience is answering correctly. Preeti?
Yeah, I think the question is very.
Answer is the option number 4, protein-based product.
Yes. So we'll go to the next slide.
Next.
This
As
we
we
have
have-
already covered.
Yes, ma'am.
We already discussed this.
Ma'am.
So move to the next slide.
Yes.
Now, all of the following are part of the MELD score. This is for the audience, except bilirubin, INR, ascites, serum creatinine. So everybody is very happily answering the correct answer. So the answer is ascites, which brings us to the next slide. Move, Ujjwal. So what are the prognostic scores which are usually used in cirrhosis?
There are various scores we use for prognosticating the cirrhosis. Initially, when child Charcot-Cook score is used for the risk assessment of the patient undergoing surgical portosystemic stent operations, but now can be used for the liver transplant patient stratification. In child Charcot-Cook score, we see for the 5 parameters: encephalopathy, ascites, bilirubin, albumin, and prothrombin time. Here are some limitations for this score, as encephalopathy and ascites are the subjective parameters, and values of the bilirubin is also arbitrary range. So new scores were developed like MELD.
Bilirubin of 5 or 4 or 15 or 20, there is no ceiling. So bilirubin is considered the same. So you cannot take into account how is the severity according to the CTP score, right?
Yes.
Now, what are the newer scores which have come up? This is not used nowadays for transplant or transplant organ allocation. No?
Newer scores like MELD score. In MELD score, we look for the creatinine, bilirubin, and international normalized ratio.
What is MELD?
Model for end-stage liver disease.
Okay.
That score is used for the liver transplant patient risk assessment and stratification. But here also there are some limitations. As in the ascites patient, we didn't count for the sodium in the MELD score. And in MELD, then MELD sodium came into the account, and MELD sodium, we take the sodium value from 125 to 140. And MELD 3, this for the women only. Here we take 2 extra parameter, age and albumin. Sorry, female gender. And albumin. Others like vocal pen score we use for the post-operative mortality.
For acute liver failure, which score is used?
King's College criteria we use.
Right. And you had mentioned about acute or chronic liver failure, right? So now we have the CLIF organ failure score, according to which either CLIF acute decompensation or acute or chronic liver failure formulas are calculated. The values are here. Anybody who is interested can go through this later. Okay. So any inflammation, once it sets in, the prognosis is going to go down south. So you have to be very careful about whether inflammation is setting in and what score you are using at what point of time. Out of the CTP score, what is associated with bad prognosis? Which class?
Class C. Not class C is associated.
And what can you find the correlation between CTP and MELD? CTP class child's A correlates with what? A MELD score of less than 10. B, 10 to 14. C,
more than 15.
That brings us to the next question.
So liver transplant is indicated if MELD score is 1, 6, second is 10, third is 14, and fourth is 22. So the question is open for the PG.
The audience can answer, please. So this was a bouncer, right? So usually MELD score more than 50, 15 or more than 15, transplant is indicated. So not the answer is not 6, 10 or 14. The range of MELD score is from 6 to 40, more than 15, liver transplant is indicated. So if it is 22, liver transplant is definitely indicated, right? And that is why some MELD exceptions have also been given. Sometimes because of the INR creatinine values, they are not that high, but the patient is sick. Why? Because he has hepatocellular carcinoma or hepatopulmonary syndrome or portopulmonary hypertension or primary hyperoxaluria. So all of these, or refractory pruritus, all of these conditions have been given, allocated higher MELD scores of 22, 24, and so on and so forth. So you have to look at the message guidelines also, that what are the MELD exceptions, okay, that everyone should know about.
Yes.
Let's move on to the next slide.
What is for the pediatric? Any score is there?
Yes, ma'am. MELD score is there for pediatrics. Similarly,
For
MELD
pediatrics.
score is there. Yes, ma'am.
And MELD score, what is the range of MELD score? It's from 6 to 40.
40, yes, ma'am. 6 to 40.
Okay. Okay. So now we are moving to the next slide. That is, what are the indications of liver transplant?
Ma'am, liver transplant is indicated when there is acute liver failure, hepatic artery thrombosis within 14 days of the liver transplant, cirrhosis with decompensation. As ma'am already told, that MELD score, if it's more than 15, liver transplant is definitely indicated. If patient has cirrhosis with hepatopulmonary syndrome and portopulmonary hypertension due to cirrhosis, primary hepatic neoplasm, and the inborn error of metabolism that are affecting the liver. So in these conditions, liver transplant is definitely indicated, ma'am.
Next slide,
Okay.
please.
And what are the contraindications?
Ma'am, contraindications of liver transplant are, first of all, is active extrahepatic malignancy. Then is intrahepatic cholangiocarcinoma, hepatocellular carcinoma outside the Millen's criteria, severe cardiopulmonary disease. For example, in patient whose ejection fraction is less than 40%, pulmonary artery pressures, as ma'am already mentioned, are more than 50, liver transplant is contraindicated. If patient has QT prolongation more than 440 milliseconds, we have to optimize these conditions, then only we can plan for transplant.
I don't think prolongation is included in this list. QT prolongation is not a contraindication. Hepatopulmonary syndrome, of course, if the PO2 values are going less than 50, then that is a contraindication. QT prolongation you will find in almost all cirrhotics, so that is never a contraindication. Okay.
Uncontrolled sepsis, active alcoholic, acute immunodeficiency syndrome, and persistent non-compliance or lack of social support. These patients, liver transplant is contraindicated, absolutely.
Okay. So, and what about the relative contraindication?
Ma'am, relative contraindications are, for example, advanced stage, portal venous thrombosis, if MELD score is less than 15, poor medical compliance or social support. These are some of the relative contraindications. We have to see other factors also while considering these contraindications, ma'am.
These are soft contraindications. Sometimes even with these present, either of these present, liver transplant is done, and good centers they are. Okay. Okay. Move on.
Can be done. So we'll move to the next slide. So what are the coagulation abnormalities basically you find in these patients?
Yes, ma'am. In chronic liver disease, they're often associated with the anemia, thrombocytopenia, and leukopenia. Anemia may be due to the upper and lower GI bleeding and splenic sequestration, endothelial dysfunction, and due to the bone marrow toxicity due to alcohol. And also there is a coagulopathy due to the disbalance between the procoagulant factor and the anticoagulant factor. In procoagulant factor, there is an increase in the bone bleedment factor and decrease in the ADAMTS13 and protein C and S. Whereas in the anticoagulant factor, there is the decreased thrombopoietin synthesis and decreased factor 2, 5, 7, 9, 10, and 11. Also, there is a vitamin K deficiency.
Okay.
So, because
so why it is important to do the coagulation means evaluation? Why it is important, Preeti? Because lot of coagulopathies which are present and liver is secreting so many. What are the various coagulation factors the liver synthesize?
Factor 2, 7, 9, and 10. Mostly, and
not just 2, 7, 9, and 10. Other than factor 8 and bone bleedment factor, these are by the endothelium. Rest everything is by the liver.
Yes.
So, but then in liver patients, they are in a very delicate state of hemostasis. Why? Because they can have a lot of bleeding and they can have a lot of thrombosis also. So in fact, severe cirrhosis or long-standing cirrhosis may have total Hypertension eventually leading to sluggish flow, development of portal vein thrombosis, which is a poor prognostic sign, right?
Yes.
So you have to assess each patient individually. So there is decrease in procoagulant factors, decrease in anticoagulant factors. Both of them can be present simultaneously. So it's a very dynamic state which can be easily disrupted by any infection, any GI bleed, right? Okay, move on to the next slide, please. So like I have said that there is a very dynamic state. So Ujjwal, can you tell me a few viscoelastic point of care tests which can be used in these patients?
Yes, ma'am. We can use, ma'am, thromboelastography or rotational thromboelastometry. Ma'am, these tests are basically based on a pin and a cup concept. Thromboelastography uses a stationary pin and a rotating cuff to detect the clot formation, whereas in ROTEM, it uses a rotating pin and a stationary cup. It signifies that whenever the clot formation starts, the movement of the pin and the cup will decrease, and the graph will broaden when the clotting starts.
So basically it is depending on the viscoelastic properties of the blood.
Properties.
As the blood clots, the movement is translated, it is stopped, it is translated into splitting of the graph. Can you move on to the next slide, please?
Yes.
And then you see this graph, which was a flat line, it has split, and then it reaches the maximum amplitude, which is the maximum strength of the clot. And then that clot starts to get light because of fibrinolysis. And at 30 minutes, how much percentage is fibrinolyzed tells you how much fibrinolysis is happening. So if you look at the different terminology, there is the R time, which is the reaction time, which is telling you about how the initial fibrin is forming. Here, coagulation cascade is activated, right? So if R time is prolonged, you would like to give what? You would like to give fresh frozen plasma.
Plasma, yes.
And if alpha angle is decreased, because it is at this point of time that the clot is increasing in strength from 2 to 20 K time, kinetics time. So fibrin cross-linking is happening. For that, what is needed is fibrinogen. So if this is prolonged or angle is reduced, alpha angle is reduced, or K time is prolonged, that indicates that the patient needs cryoprecipitate. The maximum amplitude is less. That means the platelet fibrin plug is not getting formed properly. Why? It could be because of thrombocytopenia or decreased platelet function, even if the count is normal, thrombasthenia, which is known as, or because of fibrinogen deficiency also. If the clot is formed beautifully, but it immediately comes back to the straight line, that means that lysis is happening. So lysis at 30 minutes, if it is more than 7.5%, that means that patient needs what? Needs antifibrinolytics, right? Move on to the next slide, please. So again, clot initiation, clot formation, and thrombolysis. This is the standard thromboelastography curve. In ROTEM, you have 4 different curves: extem, intem, fiftem, heptem. They tell you about each and every pathway. Okay, so all of the values which you see are very machine specific. If you're using thromboelastography, look at what their standard values are, interpret according to that. If you're using ROTEM, look what their standard values are, and interpret according to that. Okay, okay, move on to the next slide, please. Okay, now that we have seen this question, it will be easy for the audience to answer. Tranexamic acid should be given after assessment of thromboelastography A. Option 1, reaction time is prolonged. Maximum amplitude is 75 millimeters, option 2. Option 3, lysis 30 is 15%. Option 4, alpha angle is more than 50 degrees. Yes, so everyone is answering rightly because lysis time is prolonged. That means that clot is getting lysed, okay? Okay, move on to the next slide, please. So your patient has come, he has been diagnosed as a chronic liver disease patient, and now he's being evaluated for transplant. He is a child C, MELD is more than 15, definitely, has hepatopulmonary syndrome, so it is automatically 24. Now, how will you go about the evaluation of this case? What test would you like to do?
Potential liver transplant recipient are assessed by the multidisciplinary team consisting of the hepatologist, transplant surgeon, anesthetist and intensive care physician, transplant coordinator, and other health and social care professional as required. After that, there is a basic laboratory testing we were done. In that, there is a complete blood count and coagulation profile like prothrombin time, activated partial thromboplastin time, D-dimer, and kidney function test with serum electrolytes, sodium, potassium, magnesium, and calcium, and liver function test. And to rule out the infectious diseases like viral hepatitis, we do the viral markers, and tuberculosis testing, we do CBNet.
Anesthetists are very worried about cardiopulmonary system, right? So in cardiac evaluation, what all would you like to get done?
ECG and screening echo, 2D echo, and non-invasive cardiac tests like a dobutamine test.
each test you tell me what you expect to find and why are you doing it. ECG, why?
Because in ECG we can find the disturbance in the heart rhythm, abnormalities in conduction pathways, and features suggestive of myocardial ischemia. One of the main feature is you can see the corrected QT interval prolongation. That's why it is done. Its prolongation is usually defined as more than 0.47 seconds in women and 0.45 seconds in men. So it is a hallmark of cirrhotic cardiomyopathy. So we see the corrected
By echo?
by echo, ma'am, we need to assess all the cardiac chamber, valvular abnormalities, ejection fraction, if any pericardial involvement is there, because our patient also has pleural effusion, to rule out any to see for the pulmonary artery pressures. And also one of the most important parameter is right ventricular systolic pressure. That also we have to measure by echo.
And suppose the patient has some regional wall motion abnormality. What else would you like to do?
Ma'am, if my patient have regional wall motion abnormality, then I will progress to coronary angiography. I'll get the coronary angio done in order to rule out, in order to get a clear information that at what
The
extent.
angio be done in all cases scheduled for liver transplant?
No, ma'am, it's not done in all cases. It will be done only when the non-invasive stress testing, for example, dobutamine stress test is positive, or if there is an evidence of obstructive coronary artery disease on coronary angiography, or patient are symptomatic, like they have very low meds, or patient has recent history of myocardial infarction. In those patients, ma'am, I'll prefer. Otherwise, not in all patients, ma'am.
If the patient has a coronary artery calcium score, CT is usually done. So CAC score is more than 100. You get a angiography done. All right, you said exercise tolerance is very poor. You cannot assess the cardiac status. Dobutamine stress echocardiography is beautiful. Why? Because it has a very high.
Yes, ma'am. Negative predictive value.
Sensitivity.
So that is why. Okay.
Yes.
And what about
So,
pulmonary?
okay, what about the pulmonary evaluation? What things you will do?
For pulmonary evaluation, we do chest X-ray and lung ultrasound and pulmonary function test had to be done and CT for X-ray.
Okay, you have any idea about the what is saline contrast echo and for what purpose it has been done?
Yes, ma'am. Saline contrast echocardiography, we give the agitated saline by the central venous catheter to rule out the right to left side due to which force. If agitated saline reach to the left side of the heart within 3 cycles of the cardiac cycle, then it indicates that there is a cardiac shunt. That due to maybe atrial septal defect and patent foramen oval. And if it is due to the extracardiac shunt, then the agitated saline reach to the left side of the heart within 4 to 8 cycle of the cardiac cycle of the heart.
So, what is the diagnosis? If it is positive,
Within
that means
If it reach within 4 to 8 cycles, then it may indicate that there is a hepatopulmonary syndrome.
it is a gold standard.
Gold standard.
Actually, okay. And with transthoracic echocardiogram, we will find out these values. Okay, so within whether it is coming within 3 cycles or 6 to 7 cycles.
Yes.
Okay, please continue.
Okay, and the rest of the tests are mentioned in this slide. You will be doing a malignancy screening. You will be looking at the volumes. What is the bone density? Go back to the previous slide, please.
Yes, ma'am.
You will be looking at how the psychiatric consultation of that particular patient is. If it is a living donor liver transplantation, you would like to know that what is the volume of the graft that is going to come, whether it is going to be adequate or not, right? So all of this imaging part is usually being done by the surgical team. We concentrate more on the cardiopulmonary and other factors, other systems, okay? Now go on to the next slide, please. There is a question there.
They already started giving the answer actually.
Of course, you will be doing blood grouping. What is the best screening strategy for diagnosis of hepatopulmonary syndrome in patients undergoing evaluation for liver transplant? Pulse oximetry, arterial blood gas, saline contrast echo, or magnetic resonance imaging? So the answer is yes, everybody is giving it correctly. Saline contrast echo. If the bubbles reach from the in the left atrium within 4 to 8 cycles, cardiac cycles, that means there is some intrapulmonary vascular dilatation. Within 3 cycles means intracardiac. Okay, and to quantify the magnitude, we have technetium, 99 technetium, macroaggregated albumin. If that is more than 6% is reaching in the brain perfusion, that means hepatopulmonary syndrome present, and more than 20% is having a poor perfusion. Okay, move on to the next slide, please. So we understand that liver transplant surgery is very challenging. It is a major long duration surgery. There are going to be fluid shifts, blood losses, a lot of hemodynamic instability. Patient is going to be exposed for a prolonged period of time, will have hypothermia. There is an ischemic component to it because liver will be taken out of the circulation in the recipient and something new will be put. How its function is going to be, the new graft, we don't know. So that is a big query. And with ischemia, reperfusion injury is going to be. So all in all, it is a very challenging scenario. So let us move on to the surgery. Next slide, please. So what is the immediate pre-op investigation that you would like done in this case?
Yes, ma'am. In immediate preoperative processes, we do the blood test investigation in which complete blood count and coagulation profiles like activated thromboplastin times and prothrombin time and D-dimer, fibrinogens, and thromboelastography and kidney function test and blood grouping and cross matching and with serum albumin. And blood products at least 15 unit leukodepleted PRBC and 15 unit pressed frozen plasma and 15 unit cryoprecipitate, 2 single donor platelets and 10 unit random donor platelets has to be arranged. And for cardiopulmonary assessment, we get the ECG done, 1 deprior and screening echo with chest X-ray and ultrasound lung. And video consent has to be taken and also get sensitivity test done and antibiotics and antacids to be given 1 deprior.
Okay. Now move on. How are you going to? Next slide, please. So which statement is true regarding preparation for liver transplant? Coagulopathy is always corrected prior to induction. Albumin should be given if tensitis is present. Cold ischemia time of 15 to 20 hours is acceptable. Antifibrinolytics should not be used. Which is the correct statement? Please choose the audience. So albumin should be given if tensitis. Many people are correctly answering. Some are giving wrong answers also. Coagulopathy should not always be corrected. Sometimes the INR may be 1.82, but you do a thromboelastograph, it will show a prothrombotic state. So you have to look at the functional tests of coagulation before you start your correction. Ascites, if it is present, then there can be post-paracentesis circulatory dysfunction at the time of incision. So albumin should be given. A cold ischemia time in case of a diseased donor transplantation, in that case, it is up to 12 hours, not more than that. And antifibrinolytics are very frequently used. In fact, patient is given beforehand and it is continued throughout the intraoperative course, right? Go on to the next slide, please. So what is the OT check drill?
Ma'am, when we are planning to take a patient for liver transplant, we should make sure that our anesthesia workstation is ready, our airway equipments, our difficult airway cart is ready, rapid infusion system, cell saver system, volumetrics and syringe infusion pumps, arterial blood gas analysis, and thromboelastograph machine should be calibrated according to the labs. Ultrasonography, contour analysis, cardiac output monitor, defibrillator. For neuromuscular monitoring, we can use bispectral index or near infrared spectrometry. Temperature management devices we have to use as it is a prolonged surgery. So temperature monitoring is a must.
The neuromuscular monitor, okay. And what is the beauty of rapid infusion syndrome?
Ma'am, rapid infusion systems are the system for which can administer fluids rapidly during the phases of collapse. Rapidly, ma'am, at the rate of 500 ml per minute to more than 1500 ml per minute. Up till this limit, it can infuse, and that to the warm fluid. It has all the things inculcated in it only.
So it has a filter, it has pressure pumps with which you can give fluid rapidly, and this fluid is warmed. And there is an emboli detector also. So that's no thromboembolism happens through it, okay? And of course, you will be keeping all your drugs prepared, the emergency drugs, anesthetic drugs, immunosuppression drugs, antibiotics which you want to give. And because it is going to be a long duration surgery, you don't want neuropathies later on. So you will give proper ankle support the pressure points with gel pads, put an appropriate head ring, and keep everything that you need, consumables ready for all the monitors and IV access. So what emergency drugs would you prepare in this case?
Yes.
As infusions and as loading as syringes?
Yes, sir. For emergency drugs, we prepare in the infusions and for boluses doses. For infusions, we keep ready the noradrenaline 80 mics per cc and vasopressin 1 unit per cc, calcium chloride, soda bicarbonate, and 25% dextrose. And for boluses dose, we ready phenylephrine 100 mics per cc, and adrenaline 10 mics to 100 mics per cc, and
And you
whether
keep
soda
on other
mic-
it makes your crash card, so it should be fully ready, and you should
Yes,
keep
ma'am.
fluids like 5% albumin, 20% albumin also should be available, readily available. A lot of plasma light should be readily available. So let us change the slide, please. How would you monitor in a liver transplant surgery? What special monitoring will be done? Don't talk about the standard ASA monitor that we all know.
Ma'am, in liver transplant patient, first of all, standard ASA monitors that we already know, 5-lead ECG should be connected.
Don't talk about them. We know the standard ASA monitors,
Yes.
including temperature, will be done. Besides that, what
Special monitor. You
Ma'am,
tell about the
special
special monitoring.
Yes, ma'am. Ma'am, hemodynamic monitors. First of all, ma'am, before induction, only we, under local anesthesia, we should secure an arterial line for the beat-to-beat arterial monitoring. Then cardiac output monitors such as pulmonary, such as pulse contour analysis methods. For example, we can use third generation flow track, Vigilio, pulmonary artery catheter, or we can also use, if the patient does not has any esophageal varices, we can also use transesophageal echo. For
one varices also, one or two also you can use, but it has to be used in expert hands. And can you name a few pulse contour continuous cardiac output monitors?
Yes, ma'am. One of them is third generation flow track, Vigilio,
Lidco,
Lidco, yes, ma'am. Lidco and Pico, yes, ma'am.
volume. Okay, so fine. And for coagulation, we already said we'll be doing a thromboelastography. Along with that, we'll be sending intermittent lab values of INR and platelet count as well. And if a lot of oozing, we can also ask for fibrinogen. And neuromonitoring will be done. You want to maintain your anesthetic depth, so you'll be targeting your BIS between 40 to 60. And in ALF cases, transcranial Doppler is helpful to tell about how the intracranial pressures are. Okay, and ABG is very important, done very frequently before, during the dissection phase, and later on also. You look at the pH, the lactates, the pH ratios, osmolarity. You look at all the electrolytes, and there is the trend is seen rather than one absolute values, and you try to normalize the things. Okay, what are the various stages of liver transplant?
Ma'am, stages of liver transplant are basically categorized into 3 phases. It is done in 3 phases. First is a dissection phase, in which an inverted T incision is made over the abdomen and mobilization of the structures are done, as liver is a organ which is attached from all the structures. For example, spleen with a with some ligament, with kidney with a hepatorenal ligament, with mesentery it is attached. So we have to separate it from all the structures. Then hepatic artery and bile duct are divided. Then when this
mobilizing the liver in the dissection phase,
Yes,
right?
ma'am.
And in the anhepatic phase, what happens as the name suggests?
Ma'am, the liver is explanted. Mainly the liver is explanted here, and a temporary portocable shunt is made. It is
as soon as the portal vein is clamped, hepatic veins are clamped, the anhepatic phase starts because the liver is stopped. So
Yes,
then to decrease gut edema, sometimes the surgeons will make a temporary portocable shunt so that back pressures from the portal pressures don't cause gut edema or AKI, right? And
Yes.
then native liver is taken out. At this time, whether it is a diseased donor graft or a living donor graft, that will come. Benching work will be done, in which the surgeon will be anastomosis, will be looking at what the vessels are, whether middle hepatic vein has to be taken or not. Is there any hole in it? Is there any thrombi? They will be perfusing it with organ preservative solution. And then they will be preparing the IVC simultaneously. A second team will be preparing the IVC for implantation. Then they insert the new graft and do the cable anastomosis and the portal anastomosis. Once the portal perfusion is done, KY is open, portal vein is open, the graft is
reperfusion starts, ma'am. Graft reperfusion starts, and the new hepatic phase also.
So hepatic phase. So after portal vein and IVC reperfusion, once everything is okay, the Doppler is done, flows are checked, then hepatic artery anastomosis is done, then biliary reconstruction is done. Ultimately, hemostasis and closure is done in the neohepatic phase. Okay. Okay. So let us move on to the next slide. We know that transplant can be either deceased donor transplant or it can be a living donor liver transplant. Now, in diseased donor transplant, sometimes the liver is extracted along with en bloc with the IVC of the donor, right? So in this case, end-to-end anastomosis can be done, but the only problem is in that cross-clamping of IVC will be done in the recipient, which causes a lot of hemodynamic instability. So sometimes what is done is a piggyback technique, in which side-to-side anastomosis of IVC with the recipient's IVC is done, right? Now, in living donor liver transplantation, the whole liver cannot be taken out. You will either be taking the right lobe, the left lobe, and then you will be thinking of how the surgeon will be thinking of how the outflow tract is to be made. So they may be applying a graft, PTFE graft, or they may be reconstructing the middle hepatic vein so that a single outflow vessel is made and they will be anastomosing it. And then the portal vein, hepatic artery, IVC, all of them, and the biliary structures are anastomosed. So right lobe or left lobe. So that is the basic liver transplant technique. And many a times in cases where long and hepatic phase is expected, a temporary portocable shunt is made, which is taken off before reperfusion, right? Okay, now let us go on to the next slide. What are your hemodynamic rules in this particular case?
To maintain the stroke volume variation between 10 to 12 and mean arterial pressure 65 to 75 millimeter of the mercury, and urine output should be kept around 1 milliliter per kg per hour, and hemoglobin more than or equal to 8 gram per deciliter, and thromboelastography should be kept done within every 2 hourly and 5 minutes after the reperfusion.
And all parameters, metabolic parameters, as far as normal as possible.
Yes.
How will you secure the IV access in this?
Intravenous access, actually we have to, as it is a complex surgery and massive fluid shift are bound to happen, so we need a good IV access. First of all, before induction only, we'll secure at least 2 wide bore cannulas ranging from 14 to 18 gauge. Then we also require a percutaneous venous sheath of about 9 French and a central venous catheter 7 French, which can be inserted in a right internal jugular vein. So basically, ma'am, these IV accesses are required, intravenous accesses are required, ma'am.
And what will be your choice? What fluid will you connect to these IVs?
Ma'am,
Choice of fluid therapy is the balanced salt solution that may be plasma light and half normal saline. Normal saline we not use, it may cause hyperchloremic acidosis, metabolic acidosis.
You have to start a maintenance infusion. That will be 0.45 DNS. Okay, that will be started with a volumetric pump at 2 to 4 ml per kg per hour. Besides that, for losses and everything, you will be giving plasma light or balanced salt solution, as you said. For ascitic losses, you will be starting 5% albumin. If this patient has moderate ascites, we expect tapping off, or once the abdomen is open, a lot of ascitic fluid will be lost. So there will be post-paracentesis circulatory dysfunction. So you will start 5% albumin so that volume loss is replaced, right? And of course, if the coagulopathy is happening according to TEG, then you will be giving blood products according to them. And if the excessive bleeding is happening, then you want to catch up with the PRBCs targeting hemoglobin more than 7 to 8 grams per deciliter. Okay. What drug will you use for anesthetic induction?
For induction,
Just a minute. I just want to ask you how many arterial lines you will take in your patient.
Ma'am, in our patient, we'll secure 2 arterial lines. As I already mentioned that, ma'am, 1 arterial line will secure in under local anesthesia only before induction only, ma'am. The second arterial line, we can take another radial or we can take femoral line also, ma'am.
Which is better, radial or femoral?
Ma'am, radial is better, ma'am, because when the liver is explanted, ma'am, so
on the contrary, femoral is better. It reflects when you are giving very high dose vasopressors. Radial sometimes will get vasogastric. Femoral reflects better pressures. Okay. So, how will you induce this case?
We induce with the IV induction agent propofol, slowly titrated dose. If required, vasopressor may be added. And if cardiac function is impaired, then we can use ketofol and etomidate. And for muscle relaxant, we use the rofluronium 1.2 mg per kg. RSI is done in this case as patient has the ascites that may lead to the SC.
Airway is normal, you can use rofluronium. Airway is normal, use succinylcholine. And always use fentanyl before induction agent. Give fentanyl.
Yes. Okay. And for maintenance, we use the isoflurane and
try and avoid benzodiazepines. Especially this patient is in hepatic encephalopathy. We don't want to. So, fine. How will you maintain the depth?
Maintaining the depth with the isoflurane and inhalation and anesthetic agent isoflurane and opioids like fentanyl. And for muscle relaxant, we use the atracurine.
Why atracurine?
As the patient is a case of the chronic liver disease, so atracurine is metabolized by the Hoffman degradation, not by the liver.
Can you use desflurane? Any advantage of desflurane or isoflurane?
Yes.
Yes, ma'am, we can use desflurane. It is, ma'am, when the new liver is transplanted, we can better appreciate with desflurane that it is getting metabolized, ma'am.
Desflurane does not depend upon liver for metabolism.
Yes, ma'am.
That is the only beauty of desflurane. You don't, even isoflurane.
So it is not depend on, and it's a very short acting, and immediately patient can be awake. So that is the thing. And you can use remifentanil if it is available. Okay. So at present we don't have, but that's why we are using. You can tell fentanyl. Otherwise we can.
So move on to then you monitor the depth of anesthesia. These patients already have increased GABAergic transmission, so there can be already depressed mentation. So you keep the base between 40 to 60. Okay. Okay. Move on to the next slide, please. So immunosuppression is given during surgery in which stage of liver transplant? This question is for the audience. Dissection phase and hepatic phase after surgery. When is immunosuppression given? Please answer. Yes. So most of them are getting it right during the anhepatic phase before the neograft is introduced. Okay. Okay, fine. Go on to the next slide, please. What are the challenges in liver transplant surgery? Tell me phase-wise.
Ma'am, in different phases, we have different challenges. In dissection phase, firstly, as soon as the incision is made, all the ascitic fluid gets drained.
For incision, you give antibiotic. Which antibiotic do you give?
Ma'am, antibiotic is chosen on the basis of the institutional guidelines, ma'am. Ma'am, most commonly piperacillin tazobactam along with teicoplanin and metronidazole along with an antifungal fluconazole is used. This is the most common regimen, ma'am.
Broad spectrum coverage.
Broad spectrum coverage, ma'am.
Okay, fine. Now tell me challenges.
Ma'am, in the dissection phase, firstly, when the incision is made, a lot of ascitic fluid is drained. So it could cause post-paracentesis circulatory dysfunction. It could also cause hypotension. That could cause fall in the systemic vascular resistance. Blood loss can also be there during the dissection because there could be lots of adhesions, varices can be there, and splanchnic congestion is also there. During blood loss, if you are administering too much fluid, there can be dilutional coagulopathy also. So we have to take into consideration all of these things.
So these patients usually have a low SVR. They will have an SVR in the range of 400, 600, 700, unlike normal people. And once you give inhaled anesthetics, that will fall further, propofol, further fall in SVR. In manipulation, further fall in SVR in release of cytokines, inflammatory mediators. There can be endotoxemia in gut manipulation, right? So there is a fall in SVR. So how do you counteract that?
Ma'am, we can limit the volume of fluid removed to 5 to 6 liter at a time.
You are talking about post-paracentesis?
Yes, ma'am.
Sometimes the fluid will come out. You cannot limit the volume of fluid.
Yes,
You are doing albumin, okay, to replace. But
we can.
SVR, what will you do? What infusions will you start?
Yes, ma'am. We can prime our circuits with the vasopressors, and we will start the vasopressors before this stage only, so that as soon as the VP falls, we can rapidly, adequately give the vasopressors.
More than 65. So you will be starting your noradrenaline if the SVR is falling. You will be keeping a lookout at the cardiac index, the heart rate also. Okay. And you will be starting noradrenaline. If higher dose noradrenaline is being needed, you will start vasopressin as well. You will keep the why is this important? Because you want to cause splanchnic vasoconstriction so that the effective circulating volume increases and you don't have to give a lot of volume, which is also detrimental. Okay.
Yes,
and where is more blood loss expected in which types of surgeries in liver transplant? When it is a redo surgery, patient has undergone previous surgery, or patient has any infection like spontaneous bacterial peritonitis.
Yes, ma'am.
Okay, so in all of those cases, or where you are anticipating, when can you use some special equipment if you are anticipating a lot of blood loss?
Ma'am, cell salvage system we can use, ma'am.
Cell saver can be used. And when will you not use it?
In neoplasm and infections cases.
If there is infection or fine. And so these are the basic challenges. Every time they are trying to cut the ligamentous attachment, they'll be picking up the liver. That will cause what? That will cause kinking of the or pressure on the IVC. So venous return will decrease. There will be hypertension. So you have to be very careful. Sudden increase in stroke volume variation from say 8 to 18. Don't start giving volume. Look at what the surgeon is doing and communicate with the surgeons also. Okay. And besides that, you'll be doing your thrombelastography and correcting coagulopathy according to that. You will be loading the patient with antifibrinolytic tranexamic acid if needed. And of course, we'll be continuing the infusion throughout 2 mg per kg per hour, looking at the TEG values, which will be repeated every 2 hourly. Okay. And ABG will be done according to the metabolic status. If it is everything is calm, hunky-dory, you can do it. 1 or 2 hours. Things are going wrong, you have to keep correcting and retesting, right? And of course, you'll be looking at the sugars also. What are the challenges with the anhepatic phase when the liver is clamped? Not the liver, the portal vein, hepatic vein are clamped.
Because liver is explanted now, so we will face the challenge of coagulopathy. And because the liver function is absent, none of the lactate, citrate, or metabolic gluconeogenesis, these will be happening. So our patient can undergo hypoglycemia. Also, ma'am, lactic acid will accumulate. It will cause metabolic acidosis, and lactates will be high during this phase. Also, ma'am, as soon as the anhepatic phase is about to end, we give the immunosuppression, so that our patient's immune system don't attack the new liver which is implanted. So it is generally,
Use which drug? How much dose?
ma'am, methylprednisolone at 10 milligram per kg, it is usually given. In a,
To the
yeah.
center that I worked in, they have decreased
Institutional policies are different.
Yes, ma'am. Institutional policies are
है
different.
ना?
Yes, ma'am.
infection
In this
that
phase, ma'am, because massive organs are, liver is removed, so we can also face the challenge of hypothermia. So we have to use the forced air blankets and the air mattress thoroughly in order to prevent the temperature from falling.
not just the liver is removed, they have kept a neograft until the time to increase the ischemia time. Cold ischemia is given, right? So the graft is kept in ice, it is flushed with chilled organs for preservation fluid. And even when the graft is brought in the cavity, abdominal cavity, then also cold saline is put. So patient will anyways be getting hypothermia. So you have to target your temperatures more than 35, okay? Body temperatures more than 35, 36, because hypothermia will further exacerbate the coagulopathy. So you are doing all this at this point of time. You cannot do much about lactic acidosis because it is anyways going to happen. Surgical hemorrhage can happen. So you will have to be in communication with the surgical team, how the field is there any problem going on, looking at the brains. You will be correcting the coagulopathy. To some extent, you will not give a lot of volume in the anhepatic phase because that can congest the liver graft once reperfusion happens, okay? Now, how will you prepare for reperfusion?
We kept ready sodium bicarbonate to maintain the pH less than 7.1, so more than 7.1, and for keep potassium less than 4 milliequivalent per liter, and to avoid hyperkalemia, we can give GI drip, glucose insulin drip, and calcium chloride, and keep ionized calcium 1.1 to 1.3, and avoid excessive fluid. Fluid are targeted according to the mean arterial pressure and the stroke volume variations, and vasopressors are also titrated according to the mean arterial pressure and systemic vascular resistance. Nothing can be done for the lactate, and to avoid hypoglycemia, we can give dextrose 25 and maintain temperature of the patient around 35 to 36 degrees Celsius.
So that you finish your immunosuppressive drug infusion 10 minutes before, 10-15 minutes before reperfusion happens, because you don't want an anaphylaxis reaction ongoing with the reperfusion. So it's as stable as possible. And once the surgeon opens up the intrahepatic and the suprahepatic IVC, or the piggyback clamp opens up, and the graft is reperfused, what are the complications that can happen?
Ma'am, in the new this phase which you are mentioning is a neohepatic phase, ma'am. In this phase, ma'am, post reperfusion syndrome could happen, hyperkalemia, which could cause arrhythmias, acidosis, hemorrhage, graft rejection, poor graft function, and bleeding from the vascular anastomosis. These all complications could happen, ma'am.
Do you know of any organ preservative solutions?
Yes, ma'am. There are two organ preservative solution most commonly used: University of Wisconsin solution and HTK solution. The University of Wisconsin solution has higher potassium, more viscosity and biliary complications, whereas HTK solution is more preferred because it has lower viscosity, lower cost, and low risk of hyperkalemia.
Why is it called HTK?
Ma'am, because it has three components: histidine, tryptophan, and ketoglutarate, ma'am.
Can you tell me the functions of these?
Ma'am, histidine acts as a buffer. Tryptophan acts as an antioxidant, and ma'am, ketoglutarate acts as a source of
Energy substrate. Okay.
Substrate. Yes, energy substrate, ma'am.
So mostly what is now being used is
HTK solution
or liver transplantation. Okay. So this solution is being used when the bench work is being done. And like I had said, the middle hepatic vein, whether it is to be reconstructed or not, portal veins, sometimes they do retrograde flushing, so that at that particular point of time, a lot of blood loss can happen even before the neograft is reperfused. So you have to be very careful about what the surgeon is planning, how you are doing it. And What is post-reperfusion syndrome? How do you define it?
When post-reperfusion syndrome is defined as decrease in the mean arterial pressure more than 13% within 5 minutes of reperfusion, and it should last for more than 1 minute. Then it is called as post-reperfusion syndrome. It
What
is,
is
ma'am,
Why it is called?
Ma'am, it is due to the fall in the systemic vascular resistance, blood pressure, heart rate, and rise in the pulmonary vascular resistance, pulmonary arterial pressure, and high central venous pressure that could lead to right ventricular failure. Also, ma'am, when the new liver is perfused and the blood with high potassium, high lactates move to the heart, it could also cause a stunned myocardium, ma'am, due to the high potassium levels. This also that's why in the when we are preparing for reperfusion, we have to maintain the potassium levels less than 4 in order to counteract this state only.
So when you have just reperfused, always keep a lookout on the heart rate and the blood pressure.
Yes,
Both
ma'am.
of them are falling. Always build up the blood pressure a little so that it falls 30% does not go too less. Right. So you have to step up your vasopressors a little, switch off your inhaled anesthetics, and then give the body time to get that cold acidotic ischemic reperfused blood from that. And then if myocardial stunning is happening, bradycardia, hypertension, give adrenaline. If only fallen SVR is happening, give phenylephrine bolus.
Yes,
Okay. You can give calcium also if there is a myocardial stunning. That also.
Yes,
What
ma'am.
you should not do is you should not push in a lot of volume to counteract that hypertension because that will cause the congestion of the graft, which is not desired. Okay. And of course, you have said hyperkalemia, arrhythmias, hemorrhage if some clamp is left or there is some bleeder inside, sudden hemorrhage can happen. So you should be prepared with blood products if needed. And how do you know that your graft is functioning well?
When lactate level and vasopressor requirement keep on decreasing, and also there is a good urine output and bile formation start, then we think that graft
Things
is
start becoming more sunny, the vasopressors are going down, urine is coming, lactate is decreasing, acidosis is resolving. So all of these, when the picture starts becoming rosy, that means that the graft is functioning well. On the other hand, the other extreme, lactates are rising. Okay, acidosis is increasing, urine output dips, there is no bile production. So at that particular time, the graft is not functioning that well. So they always do a Doppler to look at the poppy flows and the hepatic venous flow, which is triphasic, whether it is good or not, whether the graft is congested or not. So all of that is seen. And do you extubate these patients on table?
yes, ma'am.
Every time?
Not every time.
In which conditions you will extubate and in which conditions you will not extubate? Just enumerate 4, 5.
Extubate in conditions like patient have good hemodynamic stability, following fully awake and following commands, normothermia, normoxia, and good urine output, and decreasing vasopressor requirement, then we can extubate. In not extubating conditions like if there is a massive blood loss, patient have already ASA grade 3 or 4, any
Cardiac or pulmonary issues.
and massive collaterals
that well.
and
Okay, or it is a marginal liver graft where 20% steatosis is present, or patient had a raised ICP or a high-grade encephalopathy, then maybe you would like to observe patient is hemodynamic, needs a high-dose vasopressor even now. So that time you would not extubate this patient. Can you tell me what post-operative complications may be seen?
Ma'am, post-operative complications that we can see in liver transplant are firstly bleeding we can see because of the release of any anastomosis or because various anastomoses are made during these surgeries.
Besides
Also,
anastomotic leak also, there is a raw area because the right lobe is taken, so one edge of the liver is raw. That can move. So always whenever bleeding is there, you have to differentiate between surgical and non-surgical.
Non-surgical causes.
With the help of
Thromboelastography, we can take the case.
and then you look at how much drop in hemoglobin is happening. Okay. And always take a surgical opinion if a surgical cause is anticipated. Let it be evaluated. Okay. What are the other
Hepatic complications are there like primary allograft dysfunction or non-function, IVC thrombosis, portal vein thrombosis, biliary obstruction, hepatic artery thrombosis, acute kidney injury could happen, cardio because patient's potassium level are a bit high, so arrhythmia can happen, heart failure, pleural effusion, and other metabolic complications such as hypokalemia, metabolic alkalosis, and acute rejection can happen. These
graft starts functioning, acidosis resolved, but sometimes alkalosis is seen.
Yes.
Hypokalemia is seen. Okay. And sometimes after extubation, you have to give non-invasive ventilation to these patients because there will be atelectasis because of such large volume shifts or effusions. They take some time to clear up. Do these patients have pain after surgery? They have been given such a huge Mercedes Benz incision.
No, ma'am. Most of these patients don't have post-operative pain. It is because of the contributing factors such as we give infusion of fentanyl. They have post-transplantation. They have increased metencaphalins. Also, ma'am, these patients when the liver is removed, it is removed along with the glycemic capsule and all the nerves. And the new liver which is put, it is already denervated. So these patients will not have pain. Still, we can.
Methylprednisolone, which also has
Yes.
said to have an analgesic property. So they
Methyl
don't have as
prednisone.
much pain as donors have. So, but still you can give some, if suppose the patient has a pain. So what
Sir,
are the options which you
ma'am, we
can?
can use PCA pumps, ma'am, patient controlled analgesia with a drug fentanyl, or we can give the tab blocks, subcostal tab blocks, and erector spinae plain blocks. We can give all these. We can use these multimodal analgesia option, ma'am.
Superficial pain, not visceral pain. Tab block is also helpful. And what will be the settings of the IV PCA?
In PCA pump, then we set according to the patient demand. One is the demand dose that may be set 10 to 15 mics per demand dose, and there is a lockout interval that is maybe we kept 10 minutes or 15 minutes, and hourly we set the dose that 4 or 6 dose according to
So you
patient
take
per
a
hour.
10 mic per ml concentration, and
Yes.
then 2 microgram per kg will be the maximum dose in 1 hour. Preferably keep it 1.5 microgram per kg in 1 hour. Don't keep a background infusion. Keep a demand dose only, and keep a demand dose of 2.5 ml, 0.5 mics per kg ka demand dose rakhiye. And lockout interval in IV PCA will be 5 minutes because onset time is 4 minutes. So 5 minutes, not more than 10 minutes in any case. Okay, and maximum 3 or 4 doses per hour. Okay, and then you can.
Late complications covered?
What are the late complications?
Ma'am, it can be due to the immunosuppression that we are giving. That patient is having again and again repeated infections. Graft rejection can happen, ma'am. Recurrent primary disease and the biliary tree obstruction, ma'am. These are the some of the late complications.
Sacroilimus
Okay.
nephrotoxicity happen. Hypertension can happen. Hypertension is also a sign.
Bleeding.
Yes, ma'am.
Yes, bleeding can happen because of that.
Bleeding. Hmm.
If hypertension is happening, that means that the liver graft is functioning well. SVR is rising, right? So that is also a prognostic sign. And bone marrow depression can happen with some drugs. Can you tell me the commonly used drugs for immunosuppression in the post-operative period?
Ma'am, actually immunosuppression in post-operative period is given in two phases. First is the induction phase and then is the maintenance phase. In the induction phase, we give 3 doses of calcineurin inhibitors like cyclosporin or tacrolimus, antimetabolites like mofetil mycophenolate, and along with the corticosteroids like prednisolone, or we can use hydrocortisone also. In maintenance phase, we can use calcineurin inhibitors, anti-proliferative agents, and the corticosteroids, as I already mentioned. These actually.
Harm, so you always look at the tacrolimus levels. Week-wise tacrolimus levels are different. You monitor them and then you adjust those accordingly. Mycophenolate mofetil can cause bone marrow depression, so keep a lookout on that also. And of course, steroids can be used. There can be hyperglycemia secondary to the use of steroids. And as soon as the patient is extubated, start ambulation, earlier ambulation, and give supportive therapy. And daily LFTs, RFTs are done. Doppler is done twice a day to look at the flow till the patient stabilizes. Okay. And of course, you will be doing everything you can for lung recruitment if needed. NIV, or you can give the patient incentive spirometer once the patient are extubated, right? Okay. So I think that covers the basics. And any questions can be asked the audience. Class coordinators, can you please tell us if there are questions from the audience side?
Hello.
Dr. Alok, can you just forward the questions from the chat box to madam? Dr. Alok? Madam, I think you can just address all the questions in the chat box.
Yeah, I am.
Screen coordinators, please forward the questions to madam.
Yes, ma'am.
Yeah.
There are no new questions. Ma'am, they are only the
Answers to the
previous
questions, I think.
questions.
I have not.
Ma'am, there is no questions in chat box right now.
Yeah, they have just answered the questions which we have asked. So those are the only things. So any questions from anyone?
Just to summarize, I think liver transplant is a major surgery. And this is one scenario. There can be different scenarios. There can be scenarios with hepatorenal syndrome. There can be scenarios of acute liver failure. There can be scenarios with a marginal graft. So every patient, every surgery is different, even though the surgery is liver transplant. So you have to individualize according to the kind of graft you have, according to the kind of recipient you have. So that is the challenge. And sometimes simultaneously liver kidney transplants are also done if the GFR is less than 25-30 mL per minute. So you have to be prepared for that. Perioperative dialysis also.
So optimization is also very important, and what are the various tests actually take, and our outcome is very important. So I think the centers which we are doing this um, liver transplant, I think they can just they are having some idea. Actually, we have not started doing the liver transplant as such, but theoretically, at least you can read, because you many times you will get some questions on TAG and all those things, and routinely these uh, investigations are done for coagulopathy. So you read about the liver transplant, like liver deceased donor, live donor, then TAG is important, and then what are the various stages of liver transplant and what are the complications during this. I think that is all.
So, shall I congratulate the teachers first or the students first?
The student first, sir.
The
Yeah,
students.
students first, because they exhibited a lot of
It's a
perseverance,
very huge topic actually.
good competence, a complicated topic.
Yeah.
I had few questions, but those are not related to directly to that typical optimization or a perioperative. Because many patients come when we do a selection of the patients in the surgical OPD or a gastro OPD, which are coming for the liver transplant. So during even we're going for the MELD score. So what are other criteria where we can always see these are the best patients from where we can have easy anesthesia, or these are the patients we are going to have a difficult anesthesia. So there is extreme. So in that is a very good thing to define, because liver transplant usually occurs 1 or 2 cases in even in the specialized transplant center minimum, I think
Center.
required. But every time when this patient comes, so always see this is my day, I can get this done in a very comfortable manner, or this is going to be complicated. I think Dr. Sunana is the right person to answer that, in spite of the scoring pattern.
Yes, sir. In this, actually, the more acute is the course of the illness, the more difficult the patients are going to be to manage, because they would not have had chance to have developed those collaterals and those compensatory responses. So the patients with the acute course of disease, acute decompensations, those who are having acute and chronic liver failures, because they have systemic inflammation, those who are having infection in form of spontaneous bacterial peritonitis, or who are having a poor cardiopulmonary reserve, these patients are going to be very difficult to manage. A long-standing cirrhosis, which is compensated with good collaterals, MELD may be higher, but MELD that time is, he deserves transplant, but he will behave very nicely during the transplant surgery. Similarly, hepatopulmonary syndrome, these patients desaturate very fast. So during induction, you should always have pyroxenation ready. So we stick to the basics as anesthetists, what we do. Patient having 10 ascites. 10 ascites have decreased functional residual capacity. So they will be having a decreased reserve. They desaturate very fast. So even when you're intubating, start pyroxenation in those cases. And of course, keep a lookout at how much are the losses because of ascites. Ascitic losses are a major contributor of hemodynamic instability. So keep your albumins ready for transfusion. And especially, we have had surgeries in my previous place of work where the surgery lasted, recipient surgery lasted just 8 to 10 hours and was very, very well done. On the other hand, with the same expertise of surgeon, the same anesthetic skill set, sometimes surgeries would last for 48 hours. So you can never individualize, and you can never, patients having portal hypertension, portal venous thrombosis. Sometimes the portal vein also retracts in the liver. So everybody is in a soup. Massive blood loss is happening, and you just have to keep replacing till the time the surgeon is able to do their job. Sometimes they just pack and wait till the time we have adequate hemoglobin. So every case is different, sir. But the more acute the course of the illness, more difficult it is going to be to manage. And acute liver failures are special challenges because there you have to look at the intracranial homeostasis as well, along with all this. So they
So,
are very challenging.
so what I can understand here is that one confounding factor which is noted in the textbooks is the surgical skills and acumen of the surgeon, which can never be put in the books. So whatever the surgery or anesthesia, how good anesthesiologist you may be, using health, all the skills, your all clinical acumen, all the modern equipment and drugs, but still
Yeah.
the surgical team is weak, so you are definitely going to get a
Yes.
poor result. So all your textbook knowledge goes to the dustbin when you have a very poor surgical team in
Yeah.
these type of patients. And one more query was that since you are associated with the liver transplant patients, so whenever they go for a surgery, I think one important need is the when they come up a follow-up. So since Ujjwal has given a post-operative complication, the late complication, how many times we really follow up these patients because the life expectancy come from the surgery gastro-OPD, so where the patients are usually showing a post-operative. So how anesthesiologists, get involved into that to make their life expectancy more than which usually comes in the gastro OPDs.
Yes,
The
sir.
routine.
Patients come for follow-up to the surgical OPD also. Many of them come for follow-up, and in fact, it is such a drastic change. You would see a very malnourished, frail patient with the tense ascites, poor exercise tolerance in the pre-op period. But these same patients, they come after 3 months, 6 months, and they come to meet you, especially because you have spent time with them in the liver transplant ICU. And then they are well nourished, they have built up their muscles, and they are looking bright and fresh. So we do get in touch with the recipients later on also, and it is a very good site. Some patients get stuck if there are ischemic biliary complications. Then they have to undergo stenting and all that. Then we see them in the endovascular endoscopic units or in the stenting units, ERCP suites. So we do get in touch with these patients later also. And of course, the ultimate follow-up is by the surgical team. They do assess the quality of life at different intervals. In fact, a paper was published from my recent place of work where they had mentioned how the quality of life improves after liver transplantation, after live-related liver transplantation. Unfortunately, disease donor transplantation in North India and Central India is yet to pick up. South is leading in that manner, and that is something I think everybody should be working on. Even those centers who are not doing transplantations, we should try and become organ retrieval centers so that disease donor transplant increases.
And I think the incidence is more on the northern and central India as compared to the southern or western states about the cirrhosis and end-stage liver disease.
Yeah.
And definitely, I think anesthesiologists are playing their part with the critical care advancements in the follow-up and the life expectancy of these patients. Definitely, a role is there when you have already seen the complication in the ICU. So definitely, those patients know. Even the surgical team also knows that these complications, if develop to a minute extent, intensivist or anesthesiologist is the best person to deal with. So a combined follow-up is a very good for the enhanced life expectancy in such patients.
Definitely.
Ultimately, I think it's a teamwork.
Yeah.
Like there are so many teams which are involved from the starting, from taking the patient for liver transplant and till the discharge of the patient, I think.
Going forward is a teamwork only. Going forward into the
Yeah.
future,
Such
every
a
every specialty is coming up with a subspecialty
team.
or a super specialty. Even the gastrosurgery, you will see
Hmm.
this one bifurcation for the colorectal surgery. Then you will see the liver surgery. So many surgeries. Even the colorectal surgery, you will further see after 10 years there will be rectal surgeries only. So every
Hmm.
advancement is going to take place with the super specialization and subspecialization. And those, I
Yes.
think, then the teamwork is the most important.
Most
But
important
anesthesiologists
thing.
will remain the anesthesiologist. They will be the master of almost every surgery.
Yes.
What type of anesthesia you want to give? Maybe I think transplant anesthesia, DM has already come. The DM is going on. That is definitely going to add to the advantage of these patients because
Yes.
a person like me who's giving a general anesthesia may not be well versed in the transplant anesthesia. There are so many small good things which can definitely make a good contribution to the patient's of safety and decreasing the morbidity and mortality. So these things are definitely going to be part in the future. That is, I think, going to be the part of the future transplant anesthesia. So it's a good class.
Future is for transplant anesthesia now.
I think
Heart
it is.
transplant, lung transplant, and all other things.
Anyway, this time is there for at least whatever the hard work put by the faculty today, the students today. It's a time to felicitate our faculty and the students also. So most
Thank
importantly,
you.
Vishali Venaskar ma'am, she is
Thank you. Thank
leading
you.
the team. So thank you, madam, for preparing the team in such a nice manner.
Thank you. Thank you for the opportunity.
Yeah, ma'am. And Dr. Sunaina, you are absolutely wonderful in this transplant. I got so much of knowledge today from you. I think because these things are not taught every day, there are many, I think, points which you really develop on. Those were new to me also at this stage of my life. Thank you, Dr. Sunaina, for being the teacher of the liver transplant today.
Thank you so much. I feel humbled.
Yeah.
Thank you, sir.
And your students, Vishali and Sunaina, madam, Ujjwal, as well as Preeti, both were good. They exhibited all the good confidence and they did not make any blunder with a complicated topic like that. So they were
Yes.
well prepared, I think.
Thank you, sir.
Congratulations, both of them. Their
Thank you.
pre-final
Thank you. Thank you.
pre-final is decided, and that is good enough. And then
Thank you.
Jodh,
Thank you very much.
Jodh, she has come of the night duty. She did a night duty and a very hectic with the hepatorenal patient only. This septal patients have and then stage liver disease. So she was good in anchoring. And Ashmita, she is very energetic, enthusiastic, as well as a Lok who kept a
Thank you
vigil
so much, sir.
throughout the class and could not get any question. So thank you all three of the screen coordinators. So this was a very good class, and then thanks to our class coordinators also, Dr. Madhuri, Dr. Ridhima, Dr. Nishant is not there. So they have already been preparing every team with the technical expertise. That's why it has come flawless. And Alok is the only one who was sitting idle, could not get the questions today because the class was being presented in such a nice manner. So this is from the anybody want to say anything before we will 8:30 we will close. We have got 2-3 minutes.
Sir, I would like to thank you and madam for giving me this opportunity, sir. It's my pleasure to be a screen coordinator for today's session, sir. Thank you very much for this opportunity, sir.
Yeah, your confidence will definitely take you to some other level also now. Don't worry about that part.
Thank you so much, sir.
Thank you, sir and
I will
ma'am,
also.
Yeah,
for
Alok.
making me a part of this nice case discussions.
The idea is that all the youngsters, people like you, should have a confidence. The screen presence is very important. The screen presence gives you confidence to go further. Otherwise, what happens when you suddenly go to the conference, you present somewhere, the butterflies in your stomach, na, they never allow your confidence. And when you face the people in front of you, you suddenly lose everything, the confidence, the rhythm of your presentation. So these type of, whether you are a class coordinator or screen coordinator, it gives you an ample opportunity and platform
Opportunity.
to exhibit your skills in whatever way. So that gives a confidence. So it is a good, I think youngsters should come up.
Sir, we'll like to thank our HOD ma'am and Sunana ma'am to give us this opportunity, and to you, sir, to give this
The best,
opportunity to
the
us.
best way to thank is to get good marks and good performance in the final examination. That's the best way to
Yes, sir.
thank them. They prepared you well. That's the best way to thank.
Thank you, sir.
Anybody else want to say or suggest or give good feedback about it? The class?
I believe, sir, the class was conducted very well by your team, and it was flawless, the execution right from the start, your address, Saraswati Vandana. It was fascinating to watch the Saraswati Vandana. It's been very well illustrated, the whole audio and video presentation, and the class coordinators have done a fantastic job. It
Yeah,
was
definitely.
on this online teaching.
Now the class, what I'm telling you, class coordinators have become the veterans in this type of classes. They can conduct class at a global level also. So these are our class coordinators. And with the time to come, these classes are available on YouTube. It's become a permanent property of ISA and HQ and freely available to all the students across the nation, even to the
Mm-hmm.
they can watch the YouTube and they can prepare the examination. Sometimes they do. The people
Yes.
feel very difficult to go to the books to read and sometimes what to
Mm-hmm.
read, what not to read. But in this class, Dr. Vishali and Dr. Sunana madam have covered all the questions basically. So it's a comprehensive coverage of the subject.
Yeah, you don't have to open the books, I think, for like we have mentioned maximum all the things like
But these are the complementary classes, the supplementary classes. The books have to be
Yeah.
open, ma'am. Sometimes I think
Books has to be
books are
open
the primary. Books are the primary
for
thing.
every. Yeah.
But these are the very supplementary classes. You can get the
Yeah.
good question. At least I think they can help you 30 to 40% preparation.
Yes.
Yes, sir.
Yes.
During my preparation also, I watched many ISA class videos and they were very helpful in my final practical also. And I'm very happy to be part of one of these online classes today.
Now you have become a permanent part of the classes now. Don't worry about that.
Thank you, sir.
And your work has increased in the department also. Don't worry.
Yes, sir.
So I think time is over. Nobody is giving any more.
Asking
Yeah, yeah.
questions are not there.
अरे डॉक्टर माधुरी ने क्वेश्चन नहीं पूछा आज. डॉक्टर माधुरी का क्वेश्चन आता होता लास्ट में एक. डॉक्टर माधुरी, योर क्वेश्चन.
Sir, may I ask you, sir?
Thank you.
डॉक्टर शोभा वाटकर की आवाज लग रही है.
Yeah, sir. This
देखो
was
मैडम,
very
आपकी आवाज
nice.
पहचान लेता हूँ, आपकी तो आवाज ही
Yeah.
पहचान लेता हूँ.
No, sir. This was very much in nutshell, but very comprehensive class. Like we had never come across the liver transplant. Of course, kidney transplant, yes. But the liver transplant was out of our reach. But then whatever I heard, like next time when I'm faced for that liver transplant or in the future, if I am getting, at least I am prepared 30-40%, as you said. Like I will not be that blank because initially this was not very popular, but nowadays with the increasing incidence of cirrhosis and all those acute liver failure, the liver transplants are also successful, and people are living with the liver transplant for years together. So those people, when I see the anesthetic challenges, those are given anesthesia, I really pat them for their better success. So I really feel wonder with especially Madam Karna. Her fluency was excellent, and Madam Vaishali also, and the students. They were so good. Like I really feel like listening to them for hours together. Thank you, and you
Thank
too,
you.
sir,
Thank you.
for your compliment.
Madam is
Yeah.
the regular viewer of these classes. I really
Okay.
I really
Okay.
love, because whatever we had not learned
Discussion and
initially
all.
at my
Yeah.
age,
Yeah.
like in 1982, we have been hearing those, and I'm getting updated every with every like journal clubs, as well as in my college, as my PG students, as well as whatever the things which I had forgotten earlier. But then I'm recalling my all those things. No, they are left. The touch has left, madam. That unless and until you work in the corporate, in a
Yeah.
private setup, it is very difficult. But then having knowledge always benefits whenever the thing arises. Like whenever you are caught in some difficult situation. So I'm still learning with the PG class, and it's so excellent. Like I thank Dr. Bajwa sir and those who are giving the team as well as students. They wonderfully conduct the class. Like I really thank Dr. Bajwa for so many days conducting regularly, and that's hats off to you, sir. Thank you, sir.
Not me, ma'am. It's always a teamwork. I am
Yeah.
just the coordinator only, class coordinator, and I can only bring up the talent. And actually, the classes are such that every college should get in the India to represent themselves on these classes. It's not only the
Yes.
few selected institutions, and every medical college has the potential. So even the AIMS Bhopal, say AIMS Bhopal was never in the class. Although they are preparing a huge list for that patient safety, I know that all AIMS, 20 AIMS across the nation, they're
Yeah.
preparing the patient safety classes. But
Mhm.
these classes are, another feather in the cap. So this is another thing.
That's a very good initiative, sir. In your tenure, it's a very good initiative for us to update more and more our knowledge, which was forgotten. Maybe we had learned, but by the time we practice, it has just vanished. So I really thank you for regenerating our knowledge. Thank you, sir.
Thank you, ma'am. Thank you, all the teams, all the teachers, all the
Thank you.
students,
Yeah.
and all the audience who have been a part of these classes. So next time, next either Monday or Tuesday, we'll be meeting for the next class, and we'll going to the very basics of pediatric and obstetrics physiology, adult and pediatric physiology. So that is another basic class for good for the examination, because examinations are approaching. So the basic physiology is almost 60 to 70% of IVA. Whenever those things are there, people get stuck there only. They go to the advanced anesthetic management. but the physiology they always forget. So next time we are going to cover a physiology from the northeastern part of the country, Arunachal Pradesh. So those people will be presenting the class next week. Till then, I think we should say goodbye and
Goodbye, good night.
end by saying long live ISA.